Every year in the US alone, more than 12 million traumatic wounds are treated in emergency departments, and of these, many are lacerations of the scalp. Traditionally, these wounds are cleansed and then sutured, a method often perceived as slow and painful. Sometimes the hair around the wound is shaved and a bald patch results. New studies on emergency medical care have shown that a method called the hat, or hair apposition technique, for closing scalp wounds with a person's own hair and some tissue glue is faster, effective, less painful, and has fewer complications than standard suturing. Hat requires physicians to choose 4 or 5 strands of the patient's hair on either side of the scalp laceration, crossing the strands with a single twist to close the wound, and securing the twisted strands with a drop of glue. From the article published in the July 2002 Annals of Emergency Medicine, researchers of the Department of Emergency Medicine, Singapore General Hospital, conducted the first clinical trial comparing hat to sutures. For hat, no local anesthetic injection is needed. However, we suggest using a topical anesthetic gel 10 to 15 minutes before the procedure. Next, the wound is cleansed according to standard procedure. We also recommend the use of jet irrigation using a syringe for contaminated wounds. Once cleansing is completed, dry the wound. The wound is then closed by bringing together the hair on both sides of the wound. A single twist is then made. No actual knot is made. This is then secured with tissue glue. After the procedure, the patient is instructed not to wash the wound for 2 days. No removal of stitches is required. The patient is encouraged to wash his or her hair after the 3rd day and is told that the glue will gradually fall off. During the study, all wounds were evaluated 7 days later in a non-blinded manner for satisfactory wound healing, scarring, and complications. Wound healing was satisfactory for all patients in the hat group, compared to 95.7% of suturing patients. The hat group's wounds experience less scarring and fewer overall complications, significantly lower pain scores, and shorter procedure times. In addition, there were less wound breakdown in the hat group. When patients were asked if they were willing to have hat performed in the future, 84% responded yes, 1% responded no, and the remaining 15% were unsure. Hat combines the concept of using hair knotting to oppose a scalp wound with the advantages of using tissue adhesive. Because no actual knot is formed, hair will fall back into place naturally once the adhesive has dropped off. With this technique, no shaving or trimming of the hair is necessary, making it cosmetically acceptable to patients. No removal of sutures is needed, and the glue drops off after a few weeks of normal hair washing. The study showed that suturing was associated more frequently with scarring and wound complications than hat. This may be a result of higher tension associated with sutures, which is a known factor for keloid formation. Although the study did not show any difference in infection rates, tissue adhesives theoretically have the advantage of gram-positive antimicrobial effects and of acting as their own dressing. Care, however, should be taken not to allow adhesive into the wound itself, which may cause impaired healing and foreign body reaction. The use of cyanoacrylates as tissue adhesive was first described in 1959. They have been shown to have minimal, if any, cytotoxicity. Numerous studies have shown that tissue adhesives are at least as good as sutures for closing wounds in terms of wound infection, cosmetic result, and patient's acceptance. Though no cost analysis was conducted in the study, there is significant cost savings using hat compared with sutures as a result of reduced physician and ancillary services, reduced equipment needs, and the elimination of need for suture removal. Limitations of hat include the fact that patients without hair or with very short strands would not be suitable candidates. Profusely bleeding scalp wounds, especially those due to arterial bleeding, would probably do better with sutures. And grossly contaminated wounds, which require trimming or shaving of the hair to allow proper cleansing, would not be suitable. Nevertheless, experience has shown that most scalp wounds seen in the emergency department can be suitably treated with hat, and adequate cleansing is usually possible without trimming or shaving the hair.
In conclusion, hat may be a better technique for closing suitable scalp lacerations. Advantages include fewer complications, a shorter procedure time, less pain, no need for shaving or removal of stitches, satisfactory wound healing, and high patient acceptance. We believe that hat may become the procedure of choice in emergency departments and outpatient clinics for suitable scalp lacerations.